Okay, thank you. Kisumu, you can start. And I think you can put the slides to full in the presentation mode so that it can be more clear.
That's better?
Yes, thank you.
So Dr. Christine is going to present with Dr. Laven.
Okay, morning. Dr. Christine Achola will be doing the case presentation. So, the name of the patient was DN, 2 years of age, female, who was admitted on the 8th of December 2017, has been with us in the ward for 168 days now. The chief complaints at admission, patient came as a referral from a private clinic with complaints of a mass on the face for 5 months, hotness of body for 4 days, and vomiting for 4 days. Patient was well until 5 months prior to admission, when the mother noticed a small lesion on the right side of the face, which she described looked like a boil. The mass had been progressively growing. It was painless. There wasn't any associated difficulty in breathing, and no episodes of nose bleeding. Patient had been otherwise feeding well on family diet, had not had any biopsy imaging or any medications for the mass at the time of admission. 4 days prior to admission, the child developed hotness of body that was on and off with associated sweating, did not have any episodes of convulsions, had episodes of vomiting that were mostly postprandial, and the contents were food. On examination at admission, the child was sick looking, not in respiratory distress, of good nutritional status. There was mild pallor, no cyanosis, no jaundice, no lymphadenopathy. Was saturating well at 98% with a respiratory rate of 26, temperature of 36.6, and a pulse rate of 88. On examination of the mass, there was a right facial mass, which was approximately 8 centimeters by 6 centimeters, extending from the right nasolabial fold to the right cheek region. On palpation, the consistency of the mass varied. There were areas of firmness in the nasolabial region to areas of where it was soft around the cheek region. The mass was non-tender. The right nasal cavity could, however, not be evaluated at that point. On examination of other systems, the respiratory system, the cardiovascular system, CNS, and the genitourinary system were all normal. Blood slide for malaria parasites was done, which was positive at that point, and the child was managed on artesunate and artemether-lumefantrine. There was planned to do an FNA and a biopsy, full hemogram, UECs, LFTs, CT scan and MRI could, however, not be done due to financial constraints. So this is the initial full hemogram at admission. WBC count was normal at 9.27. Neutrophils also normal at 2.55. There was some slight lymphocytosis of 5.5. Monocytes also slightly increased at 0.83. The HB was 8.3. There was a picture of a microcytic hypochromic anemia with an MCV of 55.8 and MCH of 17.2. Platelets were normal at 260. From the UECs and the LFTs done, the albumin was elevated at 410. The alkaline phosphatase was 181. The LT was 3.2. The AST was 25.5. Chloride of 107, normal. The creatinines were 17.2. The gamma GT was at 11.6 with a potassium of 4.3. Sodium was 138. Total protein of 71.4 and urea of 1.9. A biopsy had been done of the mass, and the conclusion was that there are features of primitive, small, round cell tumor consistent with embryonic rhabdomyosarcoma. The pathologist recommended immunophenotyping to be considered for a definitive diagnosis. An abdominal ultrasound done showed that the organs were essentially normal. The liver, spleen, and pancreas were normal. Both the kidneys were normal. Gallbladder was also normal. There was no mass or any ascites noted. So we had a diagnosis of rhabdomyosarcoma. So according to the preferred pre-op regimen for the management of rhabdomyosarcoma, should have been vincristine 2 milligrams per meter square with adriamycin, cyclophosphamide, and actinomycin D. The chemotherapy regimen that the child received was vincristine, adriamycin, and cyclophosphamide. Adriamycin and cyclophosphamide were given on alternative times, and the child received 10 cycles of the above. We did not have actinomycin D in the facility at that point. So these are the dates when the chemotherapy regimens are received. The pre-cycle was given on 5th of January 2018. The child received the first cycle on 12th of January. Second cycle was got on 2nd of February. Third cycle a week later on 9th of February. Fourth cycle on 2nd of March. Fifth cycle on 9th of March. 16th on the sixth cycle on the 16th of March. The seventh cycle on the 23rd of March. The eighth cycle on the 30th of March, and the ninth cycle on the 6th of April. And the 10th cycle was received on the 20th of April. There was a delay between the 9th and the 10th cycle because the child developed febrile neutropenia. So currently, the full hemogram results that were done recently, the child has a WBC count of 5.53, neutrophil decreased at 0.81, and lymphocytes at 3.35, monocytes of 1.29. The HB is at 10.7, still an almost microcytic hypochromic picture with platelets elevated at 567. The UECs done were essentially normal, with chloride of 109, creatinines of 25.6, potassium of 5, sodium of 140, and urea of 1.6. So that's the current picture of the mass. We do not have the picture of before chemotherapy, but currently the mass is about 2 centimeters by 4 centimeters. So the points of discussion today would be if we to continue with the chemotherapy dose, the chemotherapy regimen up to the 12th course, and whether to consider radiotherapy or not. Thank you.
That's the end of the presentation. So you will have some input. Thank you.
Good morning. Can you please put the mass in the picture? MRI? Do you have an MRI of the neck?
No.
Okay, so we'll need that to see if it's resectable. You said she got how many cycles of chemo for the rhabdo?
10 cycles.
Wow. Because usually you do either 4 or 6 cycles in some cases, and then you intervene, local intervention. That would be probably surgery, or we can do local radiation treatment, and then you continue to the 12th cycle. However, do you have a chest X-ray? I mean a chest CT scan, to just make sure that the disease is not metastatic.
Chest CT, no.
Do they have NHIF?
No.
I had imagine you guys drank everything.
Even I did. The last time I did, I borrowed you.
Okay, so our approach will be, number one, we need to really know what we are treating. So we need to stage that patient adequately. We need a CT scan. These sarcomas actually like going to the lungs. So probably the best thing to do is to get a CT chest, number one, and then decide on what to do. Because if we proceed and do some morbid surgery or give some expensive radiation, and yet the patient has a metastatic disease, we may not really be helping that patient. So probably what we need to do is, number one, is to do a staging CT scan of the chest, which you should have done in the beginning at least. And one of the things which you need to do is to, in fact, it should be part of treatment, is to the financial education of our patients. Because this is a chronic disease, it's going to take long, so we need actually to enable them to have all the means necessary to complete the treatment. So it will not make a lot of sense to start treatment and then you abandon halfway, just because the patient cannot afford. And things like NHIF are available. So, yeah. How can we assist them get a CT chest?
We had a team from Ampath who saw the child last week, and I think they decided that from the plan we're going to make after this discussion, they'll chip in and assist. Yeah.
Okay, so that would be great to know. So let's get at least a CT chest first, and then get an MRI of the neck to see what tumor is there, and if you can get either head and neck or some of the surgeons to assist us to resect. And if it's not resectable, we can do radiation treatment if there's no lung metastasis. But if there's lung metastasis, we'll just continue with chemo.
Thank you for that. I think that's the only presentation we had, unless there's any more contributions. We can move on.
I wanted to comment. Hello?
Yes.
Yeah, the standard treatment for rhabdomyosarcoma, we use vincristine, actinomycin B, and cyclophosphamide. Actually, the literature says that the role of the use of doxorubicin has not found any use for so many years. So probably here we just used it because of lack of actinomycin D. But otherwise, the standard role will be for us to use vincristine, actinomycin D, and cyclophosphamide. And even in some cases, when you only have vincristine and actinomycin D, then you are good to go. And then, as Dr. Chite has said, the standard way would be for us to do a few cycles, 3 to 4, or thereabout, do resection if it's resectable. And then after that, do the radiation therapy as we continue with chemotherapy. Yeah, thank you.
Thank you, Doc.
And then of
Yes.
note, finally of note, the prognosis of rhabdomyosarcoma in children between 1 to 9 years is usually very good. So if it's well managed, then the prognosis of these children will be very good. It is usually poor below 1 year and above 9 years. That is just in addition. Thank you.
Thank you for that addition also. Yeah, we've noted those and we'll take it up from there. So I think if we don't have any more contributions in this case, we can move on to our next phase, which was...
Sorry, there is one more.
Okay. Sorry, we can barely hear you. Louder, please. Hello.
What I was saying is that you should have, like what Dr. Caroline Opak has said, you should have a role for what you're treating, and the chest X-ray or the CT would have been paramount before starting treatment. And I think for this child, it's 2 years and you have undergone a lot of cycles for that. So here what we do at MTRH, we do 3 cycles, then surgery, and then maybe another 3 cycles. So I think maybe you should have a plan for the kind of chemotherapy regimen that you are giving. So, and maybe you can borrow some protocols from us so that you know how to treat them. And then the other thing is that if you don't have a drug in a facility, prudent, you can refer the patient and you don't have to give wrong therapy or treat the child because of lack of drugs. Yeah.
Maybe just to mention, a chest X-ray was done in the beginning and it was normal. Yeah. So I think we'll just follow up with the CT chest and the MRI head and neck, and plan it from there. Yeah. Thank you for that.
So is there any other contribution from any other person? So if none, I think we'll end there the case presentation. And then we are having another presentation from Dr. Peace from this side. Maybe she'll take over. Have you heard of that?
Yes, you've got a new clearly.
Yes.
Go ahead.
She's saying that we were to have we have a presentation but it is supposed to start at 9. It was scheduled to start at 9. So we are still waiting for some few people because it was communicated that it will start at 9. We had anticipated that the tumor board will end at around 9. So 9 is 20 minutes to come. So maybe you can take a breath, a sip of some tea, then we can come back for that presentation.
It's okay. Wait.
Kindly remember to come back after that. There is a presentation that was posted by Dr. Peace, so you can go through in the meantime.